Daryaganj, New Delhi, educated till 12th standard and electrician by occupation. History is given by the patient and seems reliable. Patient presented to the OPD with chief complaints of diffuse abdominal pain since 2 days, easy fatigability since 2 days, yellowish discoloration of eyes and skin since 1 day, cola-colored urine since 1 day. History of present illness. The patient was apparently well 2 days back when he started to develop diffuse abdominal pain, which was acute in onset, dull aching, continuous, non-radiating, decreased on lying down. It was associated with malaise and easy fatigability, not associated with any nausea, vomiting, diarrhea, black tarry stool. He also complains of yellowish discoloration of eyes since 1 day, not associated with itching, no history of any foul-smelling, bulky, greasy stools, difficult to flush, no history of pale color stool. He also complains of cola-colored urine since 1 day. The color of urine was same at all the time, that is no diurnal variation was seen. No history of any increased frequency of micturition, urgency, nocturia, feeling of incomplete voiding. On further inquiry, patient gives the history of recent intake of Septran 1 week back, which was prescribed at his local dispensary for 5 days due to complaints of fever and burning micturition, suggestive of any UTI. Negative history, no history of any recent travel, no history of any fever, night sweat, weight loss, no complaints of shortness of breath, chest pain, no history of any joint pain or muscle pain, no history of easy bruisability, no history of reddish spots in the skin, no history of repeated blood transfusion, no history of IV drug abuse or tattooing. Past history, no history of similar complaints in the past. He is not a known case of tuberculosis or asthma. He has never been treated for diabetes mellitus and hypertension. No history of any prolonged illness or hospitalization. No history of any previous surgeries. Family history. History of similar complaints in the brother has been reported in the past following an upper respiratory tract infection. Rest history is not there. Personal history, he is vegetarian by diet, normal sleep-wake cycle, normal bowel habits, no history of any alcohol intake, no history of smoking or any other substance abuse. Summary, my patient, 25-year-old male, with history of recent intake of Septran 1 week back, presented with chief complaints of diffuse abdominal pain and easy fatigability since 2 days, yellowish discoloration of eyes and skin, as well as cola-colored urine since 1 day, with positive family history of similar complaints, no history of any diurnal variation and any similar complaints in the past. Provisional diagnosis. The patient is a case of acute attack of hemolytic anemia, most probably due to G6 glucose phosphate dehydrogenase deficiency, precipitated by sulfur drug intake or infection. Other differential diagnosis, autoimmune hemolytic anemia, paroxysmal nocturnal hemoglobinuria, and since the patient does not have fever, I'm not sure whether to include viral hepatitis or not. So, shall I go on to examination? Hello?
Are you able to hear me now?
Yes, sir. Now you're audible.
Provisional diagnosis of acute attack of hemolytic anemia.
Yes, sir.
I'm just asking you, what clues in the history can you summarize which helped you to reach the diagnosis of acute attack of hemolytic anemia?
Oh, sir, he gave complaints of cola-colored urine which suggests of hemoglobinuria, which suggests the patient had intramuscular hemolysis, and he has yellowish discoloration since 1 day. That's why acute attack.
Okay, and did you inquire about the color of the urine, the color of the stools?
Yes, sir. The stools, there is no history of any pale colored stool, and the urine was cola colored.
Yeah, I understand that. All right, we can go on to the examination.
Okay. Examination, general physical exam.
Just wait for a moment. Okay. See, the class, this is for the rest of the class. I think I am audible to everybody.
Yes, sir. Thank you.
We are basically discussing, actually this was Dr. Suresh's class. He was not, he was in a meeting today. What we are trying to discuss is when a patient comes to you in the OPD with history of jaundice. Now that jaundice can come with fever or hepatosplenomegaly or symptoms or as a fresh case. This could be a combination of 3 or 4 things that you may have to look at. I think out of these, the liver aspect has been covered in the last 2 classes, CLD and supposedly ascites. Ascites was a different story. So now we are tackling pure jaundice. So I have 25 or 30 discussing after the case. But first, let's get an overview of how I told Madhav about hemolytic anemias would be presenting. I think Mahika has presented a very nice history, a case of hemolytic anemia presenting with an acute attack. So I think the whole uh, about how this presentation is going to be is like this. We'll have 3 different cases of 3 different presentations. Am I right, Mahika?
Yes, sir.
So we will be going about this and just keeping our thoughts on hold. We'll make a small slide at the end of the 3 cases, and then we'll begin with my presentation. And at the end, we'll have a small discussion, right?
Okay, sir.
Okay, so the one you're presenting, you may proceed with the examination.
Okay, sir.
People also to interact. Most of them are staying so silent. I don't know why the question walks. Not once you're presenting or I am presenting, after that, right? Questions
Okay,
and answers.
okay,
Come on, you can continue.
okay, sir. Examination was done in broad daylight and consent of patient taken. Patient was conscious, cooperative, and well oriented to time, place, and person. Vitals: pulse was recorded to be 104 beats per minute, regular rhythm, good volume, no specific character, symmetrical, no radial or radiofemoral delay. All peripheral pulses palpable and bilaterally symmetrical. Blood pressure 110 by 72 millimeter Hg in right brachial artery in supine position. Respiratory rate 18 breaths per minute, thoracoabdominal. Temperature 98 degree Fahrenheit. Head to the examination. General appearance of the patient is pale yellow and he's a well-built patient. Normal facial symmetry. In eyes, icterus was moderate. Icterus was present. Pallor couldn't be appreciated due to icterus. Oral cavity, lips appear normal. Orodental hygiene is maintained. Tongue pale in color. No signs of vitamin deficiency such as glossitis, chelosis, angular stomatitis seen. Chest wall, no spider nevi seen, no gynecomastia appreciated. Upper limb, no femur edema, no flapping tremors seen on extension of wrist with outstretched hand. No nail changes seen, no clubbing present, no petechial spots, no scratch marks seen, no pigmentation of skin seen. In lower limbs, no edema appreciated, no scratch marks present, no petechial spots, no ulcers seen, no cyanosis, and no lymphadenopathy. Abdomen examination. On inspection, abdomen was not distended. Umbilicus was central and inverted in position. All quadrants moved well with respiration. No visible lump. No visible dilated veins or pharma. All hernial orifices free. Palpation. Was performed with patient lying supine, exposed from beefy sternum to just above the inguinal ligament, with semi-flexion of the hip and knee joint. Superficial palpation. There was no local rise of temperature, no tenderness, no abdominal rigidity or guarding, no lump palpable. So the last point should not be included here. In deep palpation, conventional method was used. Liver was not enlarged and spleen was not palpable. On percussion, normal tympanic note was heard all over the abdomen. Percussion of liver. Upper border of liver dullness is percussed at right fifth intercostal space along the mid-clavicular line, while the lower border is just below the right costal margin. For percussion of spleen, Trobbe's phase gives tympanic note on percussion. That means spleen is not enlarged. And by Castle method, resonant note in the eighth intercostal space in the anterior axillary line with the patient lying supine. And the last point I've written is on auscultation, normal vowel sounds heard. In other systems, cardiovascular system, apex beat in left fifth intercostal space, just medial to the mid-clavicular line. Normal heart sounds heard. Respiratory, the trachea is in midline. Bilateral air entry present. Normal vesicular sounds heard on auscultation. In central nervous system, higher mental functions are intact, no focal neurological deficits present. Summary. My patient, 25-year-old male with recent intake of Septran 1 week back, presented with chief complaints of diffuse abdominal pain and easy fatigability since 2 days, yellowish discoloration of eyes and skin, as well as polar-colored urine since 1 day, with positive family history of similar complaints, no history of any diurnal variation and any similar complaints in the past. On examination, pallor is present, no feature suggestive of pallor and icterus present, no feature suggestive of portal hypertension found, and no signs of liver failure found. Provisional diagnosis: the patient is the case of acute attack of intravascular hemolytic anemia, most probably due to GCP deficiency precipitated by sulfa drug intake or an infection. And differential diagnosis still remains the same because we need to do further investigations uh, to know which is the main cause. That is the. Hello?
Maika,
Hello, sir? Yes, sir.
please come back to your slide on GPE.
Yes, sir.
I would just like to highlight some of the good points that you have taken. GPE, the next one.
Yes, sir.
See, no signs of vitamin deficiency, glossitis, stomach loss. This is a good point you have presented. Then overall, all peripheral signs of CLD have been covered. Flapping tremors, palmar erythema. Then again, no nail changes. No petechial spots could also be seen in hemolytic anemias. I'll be discussing diascopy in my slide, so it has included. And then again, lower limbs, all the most of the relevant points, excluding other systems which have caused jaundice, have been covered. So this slide, one of the prototype slides. Next, this is for rest of the class, not for Maika, obviously. Uh, this uh, next slide, next slide, next
Sir,
slide.
I wanted. Okay.
Yeah, yeah. Please tell
Sir,
me what
I
you want.
wanted to. Since the patient does not have distended abdomen, so should I write about fluid thrill? Like, should I even try because nothing can be done in there.
Mm, Fluid thrill, no shifting dullness. You might just mention that you tried doing it. That's it.
Okay.
On the percussion slide, she has very well made out the areas of splenic dullness and even minimal enlargement. We need to understand that hemolytic anemias frequently present with jaundice and splenomegaly and might not have hepatomegaly. It might just be a finger below the costal margin. So what I want to mention here is that mentioning all three is not necessary, but this will give you a good extra points when you present them to the examiner. So it's a nice effort. Next. So CVS is all intact. Next. Okay. So after this summary, next. Provisional diagnosis and the diagnosis that she's keeping is it might be hemolytic anemia, intravascular, all right. Due to what we will skip at this stage, maybe by drug intake slash infection, not just like maybe. There are so many drugs incriminated for this. Go a little broad at this point before we investigate. Hematology, it's a lot of we can't be very sure, right? Otherwise, I think it
Yes.
was a very good effort. So just let's keep this prototype and go on to the next case. Who will be presenting the next case? Thank you, Maika. Nice presentation.
Thank you.
Who
Madhav
will be
Goel.
taking the
Okay. Sir, I'll stop presenting.
okay. the
Good
slide?
morning, sir.
Can everybody see this? See the slides being presented by Madhav? Please answer.
Is my screen visible, sir?
Visible. Your audio is also clear. I think you can continue.
Okay, sir. Uh, so today I'll be presenting the case of Mr. XYZ, 32 years old male from Shahadra, Delhi, Hindu by religion, construction worker by occupation, and date of examination was 4th August 2021. The history is given by the patient himself and seems to be reliable. The patient presented to the OPD with chief complaints of recurrent and variable yellowish discoloration of eyes since 4 years, pain in the left hypochondrium since 1 year, and pain in the right hypochondrium since 2 days. History of presenting illness. The patient was apparently well 4 years back when his friend noticed a yellowish discoloration of his eyes. Uh, Onset is chronic, gradually progressive, and recurrent on and off in nature. And there was no history of itching, high colored urine, or pale stools. There was no history of joint pain or muscle pain. There was no history of shaking chills, and there was no history of any drug abuse. The patient also presented with pain in the left hypochondrium since 1 year. Onset is chronic, dragging in character, gradually progressive, no associated radiation, not associated with any vomiting, nausea or vomiting or intake of food. There were no aggravating or relieving factors, and it was relieved on taking paracetamol. There were also complaints of pain in right hypochondrium since 2 days, acute in onset, intermittent and colicky in nature, no associated radiation, not associated with nausea and vomiting or intake of food or fever, no aggravating or relieving factors. Initially, there was only discomfort, which later progressed to mild to moderate pain. It was also associated with exertional breathlessness as easy fatigability. Negative history. There were no history of any fever. There was no history of any neonatal jaundice. No history of blood transfusions. No history of alcohol intake. No history of any consanguineous marriage in the family. No history of any change in color of the urine. And there were no history of any past infections or episodic illnesses. Family history. So family history is significant, and 7 of his family members were affected with similar symptoms. Family tree is shown in the figure. Mother had prolonged jaundice and died of a similar illness at the age of 40. His 3 sisters had history of prolonged jaundice and 2 had undergone splenectomy. His 2 maternal uncles had history of prolonged jaundice and cholelithiasis and had undergone cholecystectomy and splenectomy for the same. Personal history. Uh, the patient consumes vegetarian diet. His sleep cycle is normal. There's no normal bowel and bladder habits. There's no history of consumption of alcohol, tobacco, and no history of any drug abuse. Past history. No history of any TB. The patient is also not a known case of diabetes mellitus, hypertension, heart disease, or asthma or any seizures. There's no history of blood transfusion or tattooing. Summary. My patient, Mr. XYZ, 32-year-old male, presented with chief complaints of recurrent and variable yellowish discoloration of eyes since 2 years, dragging pain in the left hypochondrium since 1 year, pain in the right hypochondrium since 2 days, associated with exertional breathlessness and easy fatigability, with a positive family history of similar complaints running in his family.
Just hold on. Just hold on. I would like to ask to the audience. There are some points which are. I think this is also a very nice history, which has we actually hope to discuss 3 short histories and 3 very focused examinations. So you might be finding a little bit of examination part being cut off, but that is what the intention was. So the question to the audience now is, you can understand this patient has a history of maybe 4 years, right? And then it has presented intermittently, or it has more of a subacute to a chronic course, and then it has flared up. So he has written this as a, what is your provisional one? Chronic hemolytic anemia. So to the audience, what could the differentials be over here? This is a provisional, and he's also made a very nice genetic chart. So the question to the audience is, what could be the differential diagnosis? I'm waiting for your answers. Could be the difference over here. Just going by the history and the points. Hereditary spherocytosis. Anisha says, okay, we'll keep that. Next. More answers, please. Just look at the age of presentation, the way it has presented. Sickle cell, maybe thalassemia, dhairya, are you talking about? Maybe not major. More answers. Does anyone of you think this could be sickle cell again, right? Do you think this could be something in hemolytic anemia? Sorry, chronic hemolytic anemia? Outside chronic hemolytic anemia, or do you just all agree with what he says? Gallstones is all right. Intermediate, yeah. Chronic lymphoid leukemia, yes, that is one differential, but that again causes hemolysis, so that enters into the same differential. Maybe outside the typical hemolytic anemias, but leukemia might episode of hemolysis. Kiranjot, right? Next, more answers, or is this limited to these 5? Okay, continue, Madhav.
Yes, sir. So differential diagnosis. So in hemolytic anemia, we can have differential diagnosis of G6PD deficiency. There can be sickle cell anemia.
Right,
This
G6PD
could
should
be,
be there on top.
sir.
Harsh is colic disease. CLL presentation is in elderly. All right, see, when we talk about presentation in elderly, this is by Anubha. It's what 70%. CLL usually does not present at a such small age. That's right, but maybe other hemolytic, other leukemic processes could be there, not CLL, but that might present with a hemolytic presentation. That is what has to be kept in mind. All right, G6PD next, Madhav.
So sickle cell anemia.
Right.
Although there would be episodic crisis in that, but I would still keep it in the differential. Uh, so hereditary spherocytosis, thalassemia. So I had a question regarding viral hepatitis. Should I keep viral hepatitis as a differential?
Going by this history of 4 years, maybe chronic hep C, but why should it present with this sort of pain and then looks more like a hemolytic process? More down, more down.
More down, like even like autoimmune hemolytic anemia should be kept above viral hepatitis.
Maybe yes.
Okay,
Just
sir.
hold for a moment. Yeah, Madhav, go on. So what? Go on.
Yes, sir. Sir, now I'll be starting the examination. On general physical examination, the patient was explained the procedure of examination. Verbal and informed consent was taken. The patient was conscious, sitting comfortably, well oriented to time, place, and person, and the patient was examined in a well-lit room. Vitals. Pulse. 90 per minute, regular rhythm, normal character and volume, no radial or radiofemoral delay. All peripheral pulses were palpable and equal bilaterally. Blood pressure was 110 by 70 mmHg, measured in the right brachial artery in supine position. Respiratory rate was 14 per minute, and thoracoabdominal, and temperature measured axillary was 98.8 Fahrenheit.
Mhm.
Head-to-toe examination. The patient looks thin-built with height 167 centimeter and weight 55 kg. The hair is thinned out and brittle. There is in eyes we have icterus that is present. Uh, the pallor is absent. Sorry, sir. The pallor could not be appreciated due to icterus. The oral cavity has poor oral hygiene. Tongue is pale in color. There's no signs of vitamin deficiency such as glossitis, chlosis, or angular stomatitis. The hands have pale palmar creases, no palmar erythema or no flapping tremors seen on extension of wrist with outstretched hands. Lower limbs show no scratch marks or petechial spots or ulcers.
Mhm.
There's no clubbing, edema, or cyanosis or lymphadenopathy present in the patient. On abdominal examination, inspection, abdomen not distended, umbilical, central, and inverted position. All quadrants move well with respiration. There's no visible lump, uh, no visible dilated veins or scar marks, and all hernia orifices are free.
Mhm.
On palpation, palpation is performed with patient lying supine, exposed from xiphisternum to just above inguinal ligament with semi-flexion of hip and knee joint. On superficial palpation, there's no local rise of temperature, no tenderness, no abdominal rigidity or guarding, and no lump palpable.
Mhm.
On deep palpation, conventional method was used, and on deep palpation revealed mild hepatomegaly of 2 centimeter below the right costal margin, soft, non-tender.
Mhm.
Deep palpation also revealed splenomegaly of 8 centimeter from left costal margin, soft and non-tender.
Mhm.
On percussion of liver, upper border of liver dullness is percussed at right fifth intercostal space along the mid-clavicular line, while the lower border is 2 centimeter below the right costal margin. Percussion of spleen. Cassell's method, dullness is observed in the ninth intercostal space in the anterior axillary line. Nixon's method, the spleen extends 8 centimeter above the left costal margin, and Trobbe's space is dull to percussion.
Right.
On auscultation, normal bowel sounds are heard, and other systems, CVS apex beat in left intercostal space, in left of the intercostal space, medial to middle clavicular line, and normal heart sounds are heard. Respiratory, middle line trachea, bilateral air entry present, normal vesicular sounds on auscultation. On CNS, higher mental functions are intact, no focal neurological deficits are present, and there are no involuntary movements as such. Provisional diagnosis. Based on the above clinical features and examination findings, my patient is probably a case of chronic hemolytic anemia, most probably hereditary spherocytosis due to chronicity of complaints, anemia, jaundice, and a positive family history. But lab
Right.
investigations are still needed to confirm the diagnosis.
Right. So can we pause here? Pause.
Yeah.
Pause. Pause. So it's question from the audience. I think he has put up a good examination where the chronicity has been displayed by even the amount of splenomegaly that the patient is having. Plus, Madhav, there is a question from your own colleagues which says that the treatment history of how each of the, did you take that? Hello,
Yes, sir. So,
Madhav,
treatment history for
there
what,
is a
sir?
question. Did you hear me?
Sir, I didn't
Can
get
you
you
hear
at the part.
the
Yes, sir.
question asked by one of your colleagues, I will not name? They said that the treatment history should be asked of how each of the 4 episodes resolved over the 4 years.
So there was no episodic history. I mean, um, like the patient presented with 4 years of chronicity, but there
That's
were
all right.
no.
Just add this as an input. how each episode of hemolysis resolved either automatically or by giving some drugs, or maybe simple observation and follow up. If that gives you a clue, the case might not need further investigations. That's a good question, I think. Uh, but sometimes what we face in the wards, this is for the person who has asked this, face in the ward, coming in de novo, just giving in a history like he has presented. He has presented a typical history of patient presenting that डॉक्टर साहब ये चल रहा था पिछले 4 साल से, बीच बीच में हो जाता था, कागज तो हमारे पास है नहीं, इलाज क्या दिया पता नहीं, बाहर प्राइवेट से या कहीं से गांव से इलाज करा रहे थे, और अब आप देख लो क्या करना है. This is the standard answer. So this is a very prototype history and examination he has presented, and I must thank Madhav for both the cases. So for the audience, can we have more differentials? We have still not ruled out the other DD. We will go on with that. Any other DD you people, or are we more focused? Question comes in, will splenomegaly pain be relieved by, it is not the splenomegaly pain which is being relieved by paracetamol. It is simply maybe the mild cholecystitis pain. Paracetamol, splenomegaly doesn't cause pain. Splenomegaly just causes a dragging sensation at the most, or maybe symptoms of early satiety because the stomach is not able to stretch out. Okay, so okay, carry on, Madhav.
Yes, sir. So, sir, my differential diagnosis will still remain the same, but most of the differentials can be ruled out on the basis of history and examination. But as I've already said, we need to do the further lab investigations to clinch the diagnosis. So, moving on. Sir, investigations would be
Go back,
CB.
go back.
Yes. Yes, sir.
Hereditary spherocytosis. See, all these three you can't just say by history on examination which is which. Maybe sometimes by some small clues, but nothing is pathognomic. So you need to investigate further. Viral hepatitis, he has put it a little bit on the, because probably he's feeling that chronic viral hepatitis needs to be ruled out. Although Hep C presents more with transaminitis, not with that amount of high icterus. Autoimmune is there, right? Thalassemia, again intermediate or minor, not major. Do we agree, Madhav?
Yes, sir. I mean, thalassemia would also present with a similar history, but there would be history of blood transfusions then, which is not present in my patient.
Yeah, in intermediate or minor, they might not be so frequent. That's okay.
Yes, sir, that's
Move on. Move on.
so investigations that I would recommend, CBC complete blood count, red blood indices, red cell indices, a reticulocyte count, peripheral blood smear, osmotic fragility test, Coombs test to rule out AI, autoimmune hemolytic anemia, liver function test to rule out hepatitis, and ultrasonography just to have an idea of
Confirm
the
or
hepatosplenomegaly.
right. Okay.
Yes, sir.
Question coming in from somebody, I will not name them again. So this can be Gilbert's also. So see, Gilbert's does present with unconscious bilirubinemia, which is present as a high colored urine, but having splenomegaly is that of this size, a little bit unlikely in Gilbert's. And the amount of bilirubin elevation in Gilbert's is not very high usually. 3, 4, 5 max bilirubin I'm talking. Fluctuating jaundice can be there in chronic Hep C also. Okay, go on, Madhav.
Yes, sir. Sir, I had a question.
Yeah.
This is basically a little case from a journal.
Okay.
In that they had asked about neonatal jaundice. So
Okay.
while I was going through the case, I couldn't understand why they asked about neonatal jaundice. Is it due to G6PD deficiency that G6PD deficiency can present as neonatal jaundice?
When they are publishing a case in journal, they are usually having covered all their bases, and that is of a teaching learning experience for posterity. If neonatal could be like the one presenting early on also, that might simply be physiological. G6PD, yes, and a whole lot of other differentials if somebody presents as jaundice in neonates. So you could include that line, but what happens is in the West, everything is very clearly documented in the form of electronic medical records. We don't have that system still in place in India, one. And two, they have so many departments sitting in. So just for the sake of discussion, like when path enters, or maybe the department of hematology enters over there, they would like to keep their differentials broad. Our calling at this point of stage is a final year learning, not a journal thing. So what we are keeping is just keep ourselves focused to how a case of jaundice might present to you in the OPD or in the emergency blocks, right? So even if we cover 80% of our differentials, that should be good enough.
Okay, sir.
You can take definitely a history of neonatal jaundice, no problem with that.
Okay, sir. So moving on to the next slide. So routine blood investigations revealed.
I think we need not discuss blood investigations over here. Just tell them what your case was.
So, sir, after doing osmotic fragility test, there was which was markedly increased. So we can see in the graph that hereditary spherocytosis revealed that there is breaking of RBCs during the testing. So my on the basis of anemia, reticulocytosis, increased MCHC, and RDW, spherocytosis on peripheral smear, indirect hyperbilirubinemia, and abnormal incubated osmotic fragility test, and positive family history, diagnosis of hereditary spherocytosis can be made.
Okay.
And so
We'll
this is the management.
we'll discuss all this once we are done with my slides. We will come back to you. I think you just keep your slides on hold. Who is presenting the third case?
Samanav.
Okay, I'll make him the presenter. Presenting Madhav. Manav is there, right? There are two Manav, right? Manav, can you start screen sharing if you are there?